Thank you very much. Thank you, Mohammed, for the presentation. I will do ask all the committee, scientific committee, for the invitation. I am very happy to be here with all of you Friday after the lunch. So I hope I can give a good lecture we can enjoy, and nobody will sleep. But I will allow us only a little nap. Okay? So the presentation, I put two highlights. One is a new hope for kidney disease. I will tell you why I use this word. And the second is a questions, and I hope through the presentation we can get the answer. We are here, and we know about the new area of the SGLT2I inhibitors, but all of the same, all are equal for us, will be in the presentation. So what I said is a new hope. I said that, this is my disclaimer, because as you know, CKD, chronic kidney disease, is really a burden around the world. Everywhere, exactly, the numbers is rising. You will see here how is the expectation, the last data we have now many years back, and what is the expectation. We will increase the percentage of patients with CKD around the world. Especially, you will see is increasing in some areas, and this is very linked with diabetes. As well, diabetes is rising, the CKD are rising. This is a very, very nice paper published a few years back only, when you can see how the expectation of the CKD and link it between CKD and death. I want this concept to be clear. The CKD patients are dying more, have more risk of death, not only cardiovascular death, also all cause of mortality. So the expectation using the statistic was in 2013, the renal cause of death or related CKD was around the position 19, but expecting in 2014, this will rise until the top 5, which is something we need to start acting now. This is a graphic, and why you will understand why we need to act in early. Our patient in CKD, you know the classification of CKD will be seen later in stage 1 to stage 5, which is in the S stage. But when the patient reaches stage 4, already increased the mortality, the risk of mortality and cardiovascular event by 3 is the reason of the hypertensive. And is diabetic, this risk increased by 6 times. So we need to act early. We don't need to wait to referral to the nephrology to take actions. When we need to wait the patient reach CKD stage 4 or CKD 5 to start to acting. As you see here in stage 3, which is the median stage for CKD, the increase in mortality risk is 4-5 times, but when you cross the border, and the border for us is stage 4, this is multiplied by 14 the risk. So I spoke directly before, CKD is linked with diabetics. Here, some statistics, they say it's 40%. I will tell you the truth. In my clinic, this is rising to 60-70% of my patients. They are diabetic patients. And as I go to my dialysis unit, this can reach to 80-90% of my patients. And what happened? We know that, all of us, we know. But in our real practice, sometimes we have a little lack of the screening, lots of early actions. And one of the points is, I will discuss today, and we'll see later in another slide, is about the early detection of the CKD, early detection of the kidney disease. Sometimes the most common, we ask in the creatinine, right? Every test, we ask in the creatinine levels, and we believe this is the only marker can tell us about the status of this patient from the kidney point of view. But I will tell you from today, many of you know, only I remember the urine. The urine is the first sign of kidney damage, not the creatinine. When we saw the creatinine high, already we are late. We lost years to give the chance to this patient to improve this condition, to reduce the progression. So the urine is the first point you can early detect it, any kidney damage. Not only diabetic, I tell you, in hypertensive and glomerular disease, any kind of disease. Ask for urine test. Urine test is something cheap, already at least this tip test. It's easy to take the samples. It's not painful test. It's costly benefit, clearly. And this study show, it's a study in Europe, +1 is more, 10 years back. It's all a study more than 50% of the patients was not tested any urine test, despite they are followed with the GP doctor, endocrinologist doctor, or the general medicine doctor regarding her diabetes. This patient, more than 50%, nobody was asking for urine test. So this is a step from the CKD point of view and diabetes. We have early interventions. We have intervention when already we proven by urine test, blood test, the patient has any kidney disease, and later we need to think and prevent the complications. So what we're expecting from this lecture, I'm expecting from now, all of us, we start to act in the yellow, intervene early, no need to wait to action. This is the last KDIGO guidelines. This guideline list has some update in 21 and 22 because we are learning, right? We are receiving new trials, new good results, and we are update the guidelines. But the concept of this, I will try to show, yes, I can use this, yes. This is how, as nephrologists, we saw the patients. This will be the classification, the old one, relate the level of creatinine, FGR, yes, and level 1 to 5. But this is alone is not enough. We need the urine test. So we add our classification, the measure of the albumin in the urine samples. So already we have the classification in blood, level 1 to 5, and in the urine, 1 to 3. And we combine this result. We combine our blood test with our urine test, and with this we try to stratify the risk of the patient to develop CKD or the risk of progression. As you saw here, why I said about the creatinine. These patients in stage 1, creatinine will be normal, but maybe the urine test show the patient has proteinuria. So the patient is high risk to progress. Despite our blood will tell me it's okay, creatinine is fine. So again, one more time, blood test, urine test, and you can use this. You can find easy in the internet, the guidelines. You can use this to help you to stratify the patients, and already stratify that the patient need to refer to nephrology, and also for you to help you how you will monitor these patients and in which stage of the risk is your patient. Diabetes affecting the kidney, especially in the area we are calling glomerular. And why we said about the proteins? Because it's damaged, we are calling the podocytes, the cells, so broken the membrane, and this is the reason we can find proteins in the urine. This is not only exclusive for diabetes, another disease can also damage, but this is a key point of the proteinuria in the urine from patients with diabetes. How is it in our hands? What can I do? I think this slide, all of you, I will go fast, you know. We have some factor we cannot modify, the genetic, the age, but you have a lot of things we do. We can do a lot of things. Encourage the patient to stop smoking, reduce the weight, control better the sugar, control better blood pressure. All these factors will help us and give time. But this precious time we gain for the patient, we need to use it also, be strong and give all the tools and medication we can give to the patient to improve. So we know CKD is a burden, we know that. We know it's not only diabetic patients, this is for nephrology also, we know it's not diabetic patients, and we need to start to thinking and give the patient which is considered the standard of care. And nowadays, from our patients, we know SGLT2 inhibitors, they are part of this standard of care. So this is the reason I said we have hope. From nephrology point of view, for our patients, only the early 2000s, when they start the losartan and the ARS and EARTH study to say, yes, patient with proteinuria, you prescribe ACE or ARBs, and the patient reduce the progression. This was, for us, a big change. We was very happy, but we know it's not enough. And we need to wait around the 20 years to give us another tool, another medication can help our patients. It was very common in my clinic to patients coming to me already in APES or RAD prescribed by endocrinology or GP doctors and ask me, you will not give nothing to me? You will not give me any tablet? I was told before, no, we don't have nothing more than that. control lifestyle, already you are in ARBS, and nothing more. This is the reason for nephrology, we are really welcome these studies, this data, because we have the hope us as doctor to help our patients. As you know, our patients, we never discharge them. We have a journey with them. They come into my CKD clinic, later go for dialysis. Some of them, they are lucky, go for transplant, but all these patients continue with us. We are continue with them. Sometimes I said, I saw them more than my family, right? I saw in dialysis unit 3 times per week. So our relation, professional and emotional, is very, very strong and very deep. So any kind of achievement in the medicine, and we know this achievement can give a hope, a expectancy of life, a quality of life to our patient, really you feel excited. You cannot deny this. So this is after the conversation, it's only my opinion. I will continue with the slides. So this is the, we are talking about the dapagliflozin and how it started. Always I said this started purely as anti-diabetic medication, but later with all the trials start to show us they have more benefit for our patients. So the Claire was with a study in diabetic patients. They have very good result cardiovascular. So later they make the DAPA, HF cardiovascular in patients with diabetic and not diabetic. And this study, the data for the cardiovascular point of view was excellent, was very good, but surprisingly, from the renal point of view, was amazing result. So from this study, we go to DAPA-CKD. DAPA-CKD is important for many points. First, include patient CKD. Majority of the trial for any drugs, one of the criteria exclusion is CKD. Any patient CKD, they are excluded for the trial. So majority of the drugs you can see in the market, they are not tested in CKD patients. So this is one good point. The another was not only for diabetic patients, was include patient diabetic and non-diabetic patients. I will go fast for the study. I'm sure many of you reading this study. This study has, for adults, was tested in adult, CKD, from CKD early, very early, when stage 1, 2 to stage 5. All the patient was with proteinuria. Also, you will see a wide range from only 200 milligrams to 5,000, that means 5 grams proteinuria. All of this patient was using ASOFARs as part of the standard of care in patient with proteinuria. Yes, and I saw before was patient with and without diabetic. So they compare the use of a standard of care, or placebo, but with a standard of care, that means ASOFAR plus ASOFARs and DAPA, 10 milligrams. And the question was, all the study, we have question to answer. The question was, the primary outcome was really pure nephrology. How is the progression, decline of HGR, progression to CKD, cardiovascular death, and later they make also focus on the cardiovascular death, heart failure, and all cause of mortality. The study, I said before, I was happy to see they are my patients. The same patient they are coming to my clinic. Majority was diabetic patient, 50%, but also you have patient with glomerulonephritis, patient with hypertensive disease, and also a group of 10% of patients with unknown CKD, which is also very common to see in our clinic. This was the etiology of the CKD and the trial. I will not go deep for that. And overall, this is the basic result, the most highlighted result we can find. So DAPA, in this case, the commercial name, as you know, is Forxiga, was showed reduce the risk of decline the kidney function, they reduce the risk to progress to kidney disease in the stage, and was this point talking about the patient need dialysis or need a kidney transplant, and reduce the cardiovascular and renal death. The numbers is really amazing. It's around 39% superior to all the another trial, also from DAPA HF. When they divide our patients, we have, as nephrology, I guess, a good surprise. The numbers for patients, diabetic patients, is 36%, which continue to be a very amazing number. But if you went to the patients without diabetics, so another pool of patients, the reduction was 50%. And more data. In this case, they are continuing with the previous analysis of DAPA-HF regarding hospitalization for heart failure, cardiovascular death, and you know also we continue with 29% relative risk reduction, which is a very interesting number for our patients. Keep with this slide, because maybe this slide will be answer our question regarding is it all LG2, they are the same. And this study, this is a combination of the overall mortality, was showing overall mortality positive results, a statistic significant result of 31% for all the death cause in the study. The study continued with more data. I will not go in deep all this data, but the concept is we have the primary outcome reached, so we proven the patient reduction to progression to end stage, patient reduces to progression to need kidney transplant or dialysis, the patient reduced the risk of cardiovascular death, the patient reduced all the mortality cause of death. So until now, our answer could be until now, with the data available, we can set it for SIG as the first and the only until this moment, SGLT2 inhibitor proven reduce the mortality or give mortality benefit to our patient with CKD in both patient CKD with diabetes and patient CKD without diabetes. So this is the resume of what we are discussing. And what I want to add this data I discussed before is all these trials, dapagliflozin was well tolerated and the data confirmed the safety profile of the medication. This is a point usually important for us. It's not only the benefit, it's not the safety profile of the patient. But it's not that the only one SGLT2 is in the market, and it's not the only one is proven can help our CKD patients. We have another study later on, which is EMPA kidney, also a study done with 6,000 patients, and a study with renal outcome as primary outcome, and with also good result. You can see here, they also fill the criteria of the reduce the progression to CKD, also fill the criteria for delayed dialysis, and also prevent our patients to decline fast the kidney function. So the primary endpoint was correct, was good benefit, but as any study, we are looking for a secondary endpoint benefit. In this case, the study no shows significant result compared DAPA. So the patients in EMPA kidney not show reduction of the cause of mortality significantly relevant or cardiovascular death. So yes, from the renal point of view, both of them, they are helping our CKD patients, but in secondary endpoint as mortality, the only, until now, for SIGA is the only one show the data for reduction all the cause of mortality and cardiovascular death in patients with CKD, with diabetes or not diabetes. So after all this data, all you know, SGLT2 start to be in all the guidelines, from cardiovascular guidelines, endocrinology guidelines, diabetes guidelines, kidney guidelines, and from 2020, especially after the publication of this trial in New England and Lancet, start to all our colleagues updating the guidelines, and now part of our standard of care, part of our treatment of care include to consider our patient as candidate to receive SGLT2 inhibitors. From the kidney, how a drug conceived as diabetic drug can help the kidney. I will go past this one. I keep this from more nephrologists. But the concept is the benefit from the renal point of view is not and reduce only the glycemic levels. It's about the hemodynamic inside the glomerular. And this is reminding us the another drugs proven, which is ACE or FARS, they are acting in the same area. Both of them, they are reducing the intraglomerular pressure. And we know if we can reduce the intraglomerular pressure, this will reduce our proteinuria. And this will be prolong the life of these glomerulars. That means prolong the life of our patients, because our patient will progress less to end the stage of kidney disease. So the hemodynamic effect as the drug is the effect give you the renal benefit. And I know some colleagues that are studying also the benefit, because you know the link between the kidney and the eyes. So I know some colleagues that start to see, and they want to prove also if this hemodynamic effect, clear proven in the kidney, has any kind of relevance in the retinopathy also. Some postulations, I will not go deep for that, this is more physiological, but they said, yes, also reduce SGLT2, reduce inflammatory markers, increase the oxygenation, increase the erythropoiesis in the kidney, reduce the intrarenal renin-angiotensin system. So all this reduce the fibrosis, the progression of fibrosis, and in the future to end this stage. So this, I think we need more information about the mechanism of action, and I know many colleagues, they are working in this research. How we can link it, the kidney and the heart. Again, the kidney and the heart, they are all together. So I think the endocrinology system, the cardiac system, and the heart, we are all together in some point. So from the point of view of help in the cardiac patients, as you know, is given for the diuretic effect, I will say natriuretic effect also, and also oncotic effect from the volume. So as you know, it has some diuretic effect, so this could be beneficial in patients with heart, but we need to be very careful in elderly patients and already patients on diuretics. So we need to assess the volume status of the patients every time we prescribe SGLT2, and sometimes we need to also modify some of the other medications. About prescriptions, about concern of safety of the medications, this is the most common questions. The patient can develop hypoglycemia. Is this good for the kidney or not? The patient has volume control, and of course, the incidence of UTI or infections. I think as new drug or new medicine, which is already in the market many years, not only now with this all new data, but I think they have a good profile safety. And if you see the data of DAPA-CKD, and compare Forxiga with another branch, placebo and standard of cares, majority of these complications, they are not significant relevant increase compared the placebo group of the patients. It's true, someone will ask me, maybe I will send about the urinary infections, which is a little more high in the group of, in this case, Forxiga, because it's from DAPA study. For these things, always I give one example, because I received one patient a few months back. She's a kidney transplant patient, cardiac patient, and of course diabetic patients. So from one of my colleagues, she's an elderly female, 70s, prescribed Forxiga. For these patients, because it's my patient, as it's an immunosuppression medication, she was admitted 3 times in the hospital with sepsis, and was receiving IV antibiotic. So in this cases, particular profile with the extremely high risk and the benefit, maybe I will not prescribe. Was Forxiga, I tell you because of Mohammed, was Forxiga. I said, I will not prescribe, because I think the safety for this patient was priority to the benefit can receive elderly patients with recurrent admission in the hospital with sepsis. But this is one case. For your knowledge regarding the infection and the risk is, I have patient transplant, that means patient with immunity reduced, patient CKD already they are immunocompromised, and more than 2-3 years I follow these patients, I don't have any UTI of them. any of them receive any admission related UTI or sepsis more than the expected or normal according. So I think this is mild increase is we chose the patient properly, really we can offer the patient more benefit. So for a few episodes of UTI, don't prescribe now SGLT2 to one patient and not give the chance to reduce the mortality, don't give the chance to progress the CKD, I think it's not correct. So please don't be afraid of the urinary infections, only be careful. All the data for our patients, all these trials, they include 32,000 patients and show all the data about the side effects. So I think about the safety concern, we need to really not thinking about that. We need to treat it our patient. Of course, we need to be aware and monitor any side effect, report the side effect is needed, but we need to balance really the risk benefit of our patients. This is another question I received many times, is I can use SGLT2 to the RAS system blockers? My answer, of course, is yes, but not you can use, you must use. You must. It's true, you will see, it's very common to, yes, I give Forxiga, and my patient after 2-3 weeks or 1 month deteriorate the kidney function, so I stop it. This is a very common scenario because it's damage to the kidney. This is a hemodynamic effect, transitory effect. This is for the quick or fast reduction of intraglomerular pressure. So temporary, yes, the patient can be reduced, the FGF, but we know, and the data show, later become stable, and with the time, the patient will get the benefit. So we are not used as a stopper. Now we start to, in the beginning, that after 2 weeks, they started do blood tests after 1 month. Nowadays, we start to postpone this. We understand it's a hemodynamic effect in majority of the patients, so don't feel afraid of already of this small reduction, because the data show, as you will see here, and long term, yes, the patient on DAPA has better outcome than the patient without. And already was not only for DAPA studies, another studies, CAMBA, EMPA, proving the benefit of use the RAS system inhibitor with SGLT2 inhibitor. So you need to consider this, because the action is different. One will act in the afferent, doing constriction of the afferent arteriola, and the RAS blocker system will be efferent vasodilatation. So what we'll do is make the intravascular pressure go more down. The effect will be more deep, so will be give our patients more prolonged delayed of the CKD evolution. This is what we want. So they have a complementary pathway to the RAS inhibition to lower intraglomerular pressure and protect the nephrons. So this is the last European Association recommendations. For us now, SGLT2 is part of our medications, is part of our treatment, especially in patients they are in CKD3 or FGR is less than 60, and or patients with microalbuminuria, which is only level of albumin more than 30 milligrams. These patients, if we want to give the standard of care, we need to prescribe SGLT2. Regarding diabetic or not, and now we know also, we are agreeing, all these medicines show a safety profile. Already this is in our guidelines, CKD, GO-CKD, and diabetics. This is a 2022, update in 21, I did, and you will see is part in the same level with the RAS blocking system. So we need to prescribe to the patients. How prescribe? Usually it's very easy, it's once a day. We have only one dosage, 10 milligrams. For the kidney patient, no need adjustment. We can prescribe no need titration. We can prescribe in also advanced case, no need to wait to the patient, to the nephrology to prescribe, no need. You can do it. As approval here in Bahrain, we can do in any patient with CKD4, that means FGR more than 25, we can prescribe once a day, no regulation, and we can keep until the patient got in the stage, or the patient go, for example, to dialysis, no need to remove. And only like advance, informal advance, our colleagues, they are prescribing now and send dialysis patients. Because especially, you know, some dialysis patients also, they are keeping some urine, residual urine. So we will wait this study for my colleagues. So for nephrology point of view, really give you a hope. We have a chance to offer something more to our patients. And my experience using really is, I am absolutely happy. About the proteinuria, I want to say I have case was 6 grams proteinuria. The only medication started was Forxiga, was DAPA at this moment. And the patient now is followed with me, is a diabetic patient, diabetic nephropathy, with the proteinuria is less than 1 gram. Already she was in another ARBs, and she has excellent control of the blood pressure also with minimal adjusted medication, good control of the sugar, and the kidney, after 3 years, the kidney function is not deteriorating, keeping it stable. She's in CKD3, and this is one case, simple, because it was one of the first patients I introduced it after our guidelines. For more confidence for you, as nephrology, we are using in non-diabetic patients. Any of my patients develop hypoglycemia, they are not diabetic. We are using in elderly patients, we are using patient cardiac with a lot of medications. So I think really we have a new chance to provide our patients with the future and a hope. Thank you.